this talk is on a lighter mode about whether our TKR Arthrotomy's approaches makes any difference to our outcomes. So the choices for a young budding orthopedic surgeon once he comes in arthroplasty is whether he needs to go with the conventional MPP approach, or there are multiple approaches which are given, like mid-vastus, sub-vastus, trivector approach, lateral patellar approach, and MIS techniques which are in today's era. So the choice is like this. All the beauties are good. You have to decide whichever you like the most. So all of us are very versed with all the approaches. All have tried one or the other ones. All have their own tips and tricks of doing it. And there are more than 10 different types of approaches for the TKR. But here I'll mainly focus for the primary TKR. And we'll discuss the pros and cons with each one associated. So basically the types have been divided into quadriceps sparing approaches and the ones which violate the quadriceps mechanism. So the gold standard, the medial parapatellar approach and the lateral parapatellar approach are the ones in which the quadriceps, we have to violate the quadriceps mechanism. And the rest, the mid-vastus, the sub-vastus, the trivector approaches, and the mini versions of them are the quadriceps sparing approaches. So first coming upon the medial parapatellar approach, which is gold standard, and most of the 90% of the orthopedic surgeons are well versed and are doing the MPP approach. It gives an excellent exposure, it is safe and easy, and the superior extension, if required, is very easy in difficult situations. But it violates the extension mechanism and has some sorts of patellar complications associated, and it delays the rehab. The sub-vastus approach or the southern approach is the most in approach in today's world, and it preserves the entire extensor mechanism. It is associated with the literature says the less post-op pain and very early rehab, and preserves the patellar blood supplies throughout. So it is well versed and it is quite okay. But the most important problem says in obese patient there is difficulty in exposure and there is difficulty in patients with patella baja. The mid-vastus approach is the middleman between both of them, and I'm myself I'm a mid-vastus surgeon. And it is a very good approach for because it's a quadriceps sparing approach and associated with very good patellar tracking. But it carries a risk of descending genicular artery injury if we go more than 6 centimeters up in the through the vastus muscles. The lateral approach is basically kept reserved for valgus knees or lateral unis. It is technically demanding. The patellar tendon must be freed in this, and it mostly needs to be combined with a TTO. The trivector approach was introduced for the shortcomings of MPP. It begins 2 centimeters medial to the quadriceps tendon, and then it runs through the VMO fibers along the patella. So it has a very acute problem of VMO disruption if it inadvertently we release the whole of the VMO. So that's why this didn't come into much of in practice. And most of the approaches are in the MIS TKA. Most of them have been introduced in mini mid-vastus, medial parapatellar, mini sub-vastus approaches. But there is a lot of debate in all the literatures about actually the utility of these, because there are short-term gains only in like decreased blood loss, quick regain of SLR, and slightly better knee scores. But it is associated with poor exposure. It all requires MIS instrumentation. It increases the surgical duration, and due to much of retraction of soft tissues, the literature has reported that these mini approaches are associated with post-op infections. So if coming on to the literature review, what does the literature has to say about it? So most of the literature has compared the gold standard MPP with the sub-vastus or the mid-vastus or the trivector approaches. So if we go to the sub-vastus approach, the sub-vastus is a very good literature support. The effort open review suggests that the active SLR is very early in sub-vastus. There is very better pain scores in early post-op periods, and the range of motion at 4 weeks are equal and at 1 year follow-up. But there is the compelling benefits of subvastus in early post-op period. So basically, functionality-wise, subvastus is quite early in the early post-op, but it becomes equal at 1 year follow-up. Similar to midvastus, again there is statistical difference between in pain scores, ROM and the knee scores at 6 months post-op, but the results become equal at 1 year, 2 years and 3 years follow-up. Same things with the trivector, that the quadriceps power is much better and the strength is quite better at 6 months, and it can be extensile and it is better in obese people. So all these approaches, when compared to the medial parapatellar approach, are statically non-significant on a long term, but functionality wise, they have a better utility and a better pain outcomes at less than 6 months post-op. So this is a good review article given by from China, which compares all the different studies, and they have pulled out a group of almost 4,000 knees, and they have found out that the midvastus and the subvastus was a top choice to decrease the post-operative time. Mini midvastus takes the least time for the active SLR to come back, and MPP is very good for the improving the post-op range of motion. But overall complication, there was absolutely no difference. So the take-home message is that functional and objective overall effect after a total knee on long-term is regardless of the approach. It only depends on how well you have performed your knee. Quadriceps strength and pain are the main obstacles to patients' functional recovery, as these factors are closely related to disability, patient satisfaction, and quality of life. So, in today's era, when the aim is less pain and faster recovery, which we all aim for, so midvastus and subvastus approach has offered an edge ahead of MPP. Thank you.